Your lecturer is Dr. Roy Benarock. Dr. Benarock is a general pediatrician, an author, and an educator. He earned his medical degree at Emory University and completed his residency through Emory's affiliated hospitals, serving as chief resident and instructor of pediatrics. He has continued his involvement on the Emory faculty as an adjunct assistant professor of pediatrics. Dr. Benarock is board certified in general pediatrics and works in full-time pediatric practice near Atlanta, Georgia. He has published 2 books on parenting and pediatric health topics and writes a blog for parents and health professionals. His essays on pediatric health have been widely published on the internet, and he has served as a featured expert on WebMD.com.
Welcome to Medical School for Everyone, Pediatrics Grand Rounds. You are a third-year medical student, and it's time to start your pediatrics rotation. You've already had your basic science courses, and now you'll start working with patients. Little patients, mostly. This is pediatrics, though since we'll be seeing patients through age 21, some of them might actually be taller than you. Now, I know you might feel that your basic science knowledge is a little rusty. So during this course, we'll be sure to cover the background you need to understand pediatric care. Biochemistry, anatomy, physiology, we'll review those when needed, but for now, what we're going to focus on here are patients, their problems, and their stories. That's really how you learn medicine. Though I am a doctor, I'm not your doctor, and I'm not your kid's doctor either. This course isn't meant to give medical advice for any specific patient or any specific child you might be worried about. If you've got medical questions about your children, you need to contact your own doctor. Also, listening or watching this course will not turn you into a qualified pediatric healthcare provider, though I hope that perhaps some of you will be inspired to continue your medical education. In this course, what you will learn includes a lot about symptoms and diseases, how doctors make a diagnosis, and how we help our young patients stay healthy. Most importantly, this course will help you learn how doctors think about children and their medical problems. Though children are unique, many of these lessons apply to adults too. And of course, it's adults who usually bring our patients, the children, in for care. So whether you're a caretaker, a parent, or just an adult who's concerned about the health of kids, you will benefit from a better understanding of pediatric medicine. We're going to structure this course as a series of grand rounds teaching cases. You'll meet the patients, I'll give you the clues, and we'll figure out the diagnosis together. Now, don't worry, by the end of this course, I promise you'll get the hang of it, and I'll bet you'll get to at least some of the diagnoses before I do. To set the stage, I'd like to start with a patient you've heard of, a famous person whose story you already know. Her name was Helen, and she was born in Alabama in 1880. By her own reports, later collected into an autobiography, she was a healthy baby until the winter of 1882, when she developed a fever. In her own words, "In the dreary month of February came the illness which closed my eyes and ears and plunged me into the unconsciousness of a newborn baby. They called it acute congestion of the stomach and brain. The doctor thought I could not live. Early one morning, however, the fever left me as suddenly and mysteriously as it had come. There was great rejoicing in the family that morning, but no one, not even the doctor, knew that I should never see or hear." That quote is from Helen Keller's autobiography, The Story of My Life. Ms. Keller was born with sight and hearing until those abilities were robbed from her by a febrile illness, that is, an illness that included fever, at 19 months of age. How did fever make her so sick, leaving her blind and deaf? What would have happened to the same child with the same symptoms and the same illness today? Let's find out together. We're now back in modern times. Today, we're seeing pediatric patients in an emergency department. Our last patient of the shift is another 19-month-old Helen, modern Helen, and her mother brought her here because she's worried about her child's fever. Helen, we learn, had been feeling well until the middle of the night, about 12 hours ago. It's always the middle of the night when kids get sick. Every parent knows that. Mom heard her fussing in her room, and when she went to see her, she was crying and felt warm. Mom measured a temperature of 101.7 degrees. She gave Helen a dose of acetaminophen, that often goes by the brand name Tylenol, and after a little while, Helen fell back asleep. In the morning, that is this morning, she awoke again with a temperature, which again seemed to improve after acetaminophen. But she later threw up her breakfast, so Mom brought her in to see us. Helen has had no other symptoms, no cough, no runny nose, no diarrhea, just the fever and that one episode of vomiting. Mom says Helen has no important past medical history and her immunizations are up to date. She goes to a group daycare 3 days a week, though Mom says, as far as she knows, there hasn't been anyone sick there lately. We don't have a lot of history here. Helen had an elevated temperature of 101.7 and she threw up once, but that's enough to start with. Let's move on to our physical exam and see what clues we can find there. I like to start a pediatric physical exam with an overall impression of how children look. There's a good medical reason for that. A first gestalt look at a child often will tell you if they're sick or well. A well child acts his or her age. As an infant, smiling and interacting, or as a teenager, sometimes sullen or looking down. A well 2-year-old might act shy and scared to see you. The bottom line is that a well child is acting right, doing what you expect a child of that age to do. But a sick child, the way a pediatrician looks at it, a sick child acts sick, not perky, not smiling, not interacting, just blah and flat and, well, sick. Even a sullen teenager will be interactive if you can engage them in conversation. And if a child of any age is not interactive, that's an important red flag. I said there's a good medical reason to start with an overall impression, but there's a practical reason too. In pediatrics especially, some of our patients are, well, not happy to see us. We'd love to use our Jedi mind tricks and distraction to get a good exam, but that's not always possible. Even taking simple vital signs, a temperature and a blood pressure, may be impossible in a child who's screaming and kicking. Sometimes that gestalt first impression is all you get, so you had better pay attention to your patient even before you start your hands-on physical examination. Back to Helen. She's sitting in Mom's lap, leaning away from you, and her eyes look glassy. In fact, you think she looks about half asleep. When you wave or motion for a high five, she doesn't react. When you or your nurse tries to check her temperature with an axillary thermometer under her armpit, she kind of whimpers or cries softly. She doesn't vigorously push anyone away or try to climb away up on her mom, or even bury her face in Mom's chest. She just whimpers and then looks down and seems to nod off. What do you think? Is Helen sick or is Helen well? We know from just a few moments of observation that she is sick. This is not how a 19-month-old typically behaves. Pediatricians sometimes use the word toxic to describe a child like this, listless, not interactive, sleepy, and withdrawn. We have great respect for and fear of the toxic child. We'd better pay close attention to try to figure out what's going on. Helen now lets us take vital signs, and we've got a temperature of 102.3, pulse 140, and a respiratory rate of 36 breaths per minute. Now, you may not be used to pediatric vital signs yet, so I will just tell you that the pulse and respiratory rates are high, though not unexpectedly high for that amount of fever. Fevers always drive up the heart and respiratory rates. The remainder of the exam is difficult. Helen starts to cry, and you can't really get a good listen to her chest, that is to her heart and her lungs. As far as you can tell, her belly is soft and not tender or painful to touch, but she seems to get especially upset when you try to move her body or move her limbs. She sits kind of still, just whimpering and crying as you try to examine her. You examine her hands and her feet. The color and pulses are good, but when you press and then remove your thumb from her skin, it takes a few seconds for that pink color to return. You try to get Mom to put her down, to watch her walk. Nothing doing. She just won't cooperate. Or maybe she finds it painful to walk or is unable to walk. You just can't tell. When you finish trying to touch her, Helen quiets down and seems to fall asleep again in Mom's lap. One of the challenges we face in evaluating our pediatric patients is that many of them can't talk or explain what's going on. Even once they can talk, they're not always willing to talk. We have to get our clues more indirectly by observation and by asking parents. And even then, we need to keep in mind that we sometimes lack the whole story. Sometimes it can help to back off, to leave, or just sit back and chat and try to return to the exam later. But today, we're in a bit of a hurry. We want to get as good an exam as possible, but we're also worried that Helen looks genuinely sick. We may need to make some decisions based on the best exam we can get, even if it isn't a very good one. In Helen Keller's case, in 1882, the story was about the same as what we've heard today, a 19-month-old girl with fever and probably vomiting. Helen Keller was diagnosed with, quote, acute congestion of the stomach and brain, which, to the thinking of 19th century physicians, fit her symptoms well. Congestion, then, was a broad term referring to excessive fluids in the body tissues or in a specific organ. Often, the excessive fluid was blood, or was thought to be blood. The usage harkens back to the ancient Greeks and Hippocrates, who taught that balancing the four humors, one of which was blood, could maintain and restore health. By the 1880s, humoral theory was gradually being replaced by newer ideas about health, but the idea persisted that excessive fluids of some kind, that is, congestion, was still a common cause of illness. So why would Helen Keller's physicians think she had congestion? One of her symptoms is that she's acting sleepy, and this was thought to be a symptom of brain congestion. This was also often accompanied by a fever. She probably also had vomiting, similar to our patient Helen, which when combined with fever could have been thought of as stomach congestion. Again, back to the humors, blood was thought to be a hot element, and excessive blood caused both congestion and fever, especially high fevers, which in the time of Helen Keller was an ominous sign of illness. Ms. Keller later wrote, "The doctor thought I could not live." Most of the time, when 19th century physicians were faced with fever in a child who was acting ill, there was very little hope. But our Helen, in front of us now, let's think about her presentation from a more modern point of view. First, let's make a problem list. That's a list we'll keep in mind, a mental list of what problems she has, especially the most pressing problems. We've got number 1, fever, and we don't know the cause of that yet. Number 2, sleepiness or a decreased level of consciousness. And number 3, vomiting. Of these 3, the one that demands the more urgent attention is number 2. She's not acting right. And that's something that in pediatrics and adult medicine is a big red waving flag. We'll be hearing more about red flags, those findings on a history or physical exam or lab test that mean Look here, you need to pay attention. A 19-month-old with a fever who's acting well, that's a child who could wait a bit. We'd try to get more history or try to repeat the physical exam, but our Helen is acting unwell, which means we need to press ahead now. One important cause of sleepiness or decreased activity during a fever is the fever itself. Though fevers themselves can't harm anyone, they do make children and adults feel achy and uncomfortable and unwell. We'll give Helen a dose of a fever-reducing medicine, not because we need that number, that temperature to go down, but because we hope it will help her perk up and feel better. Another potential cause of Helen's sleepiness is dehydration. She's been running a fever, which can deplete the body of moisture from fast breathing and evaporative losses. Plus, she had some vomiting, and since she hasn't really been feeling well, she probably hasn't been drinking well either. Anyone with a fever needs to take in extra fluids. If Helen is more than mildly dehydrated, she may not have enough circulating blood volume to get enough oxygen and nutrients to her brain, which can make her act sleepy. The medical term for this is hypovolemic shock. Inadequate blood volume providing inadequate tissue circulation, leading to symptoms of organ dysfunction, in this case, brain dysfunction. Assessing the hydration status of a child is especially important because children are more prone than adults to become dehydrated when they're ill. They have a relatively high proportion of body surface area to mass, so they can lose a lot of fluid from evaporation. They're not as likely to keep drinking when they feel sick, and they tend to run more fevers than adults when they get ill. All of this can contribute to insufficient body fluids, especially if there has also been vomiting or diarrhea. The best single test for hydration status is a child's overall sensorium or level of consciousness. That same gestalt we mentioned earlier. A child who is perky and laughing and walking around is not dehydrated. A child who's sleepy or not active, that's a child we need to be wary of. Now, things other than dehydration can cause sleepiness, a drug ingestion, head trauma, low blood sugar, all sorts of things. So in an ill, listless child, we need to think about dehydration, but also many other possibilities. There are other things we can look for, too, to help decide if Helen is dehydrated. A dry, tacky mouth or warm, dry skin suggests dehydration, as does infrequent urination or urinating very dark or amber-colored urine. Most children will need to urinate at least every 4 hours or so through the daytime. And Mom says she can't remember if Helen has had a wet diaper at all today. Another physical exam finding, we mentioned it earlier, is to check what's called the capillary refill. You squeeze or press on a toe or a finger and then watch how long it takes for the pink color to come back. In most children and adults, color should return instantly, or at most within a second. A capillary refill time of 2 seconds or more suggests circulation is poor, and in children that's often, though not always, caused by dehydration. And one last thing to check, it's simple and easy if you're lucky. If you happen to know a very recent or well-measured weight on a child, not a weight from a home scale, but a good exact hospital or medical scale, you can compare that with a current weight to see how much fluid a child has lost. A weight loss over a day or two is only from water loss, and 1 pint of water weighs 1 pound. So if we knew Helen's exact weight a few days or a week ago, we can compare it with today's weight to estimate her fluid loss. If she's 2 pounds lighter, that's 2 pints of fluids down. Children can usually tolerate up to a 5% fluid loss without becoming markedly ill or needing IV fluids. But over a 10% loss in body water usually correlates with severe clinical dehydration. We don't have a recent weight, but our clinical impression is that Helen is acting quite sleepy with a delayed capillary refill. This is consistent with significant dehydration, but in a way, The story doesn't fit. After all, she hasn't vomited that much, only once, and she's only had the fever for about 12 hours. How did she get so dehydrated this fast? Or is there more going on here? We spoke of dehydration and hypovolemic shock as a cause for her to present like this, but it's not the only cause. What more could be going on? We had given Helen some acetaminophen or Tylenol earlier to reduce her fever. She took that and didn't vomit it back up, but she refused to drink further from a cup when offered. Mom's been trying, and it isn't working. So it's time to get an IV started to run in fluids. We don't know the whole story yet, but we know that Helen's acting sleepy and has findings suggesting dehydration, or maybe something else on top of that. Before starting the IV, we tried to repeat the exam again. It's been about 20 minutes. The acetaminophen should be kicking in, and she's asleep. Her vitals now include a heart rate of 160. That's heading up, even though her measured temperature is down to 100.7. And her capillary refill remains slow. This time, she didn't fuss much with the exam until you raised up her legs towards her belly. That made her upset. But it was when you tried to bend her head down gently towards her chest that she really resisted your exam. You tried to get her to look down by shaking a toy, and then you gently tried to move her neck yourself. Nothing doing. That neck is stiff, and it will not move. Fever, vomiting, sleepiness, and now stiff neck. All of this suggests a significant infection. It could be an abscess or infection in her neck, though those usually arise as a complication of a throat infection, and she never really had a sore throat. Or, more ominously, Helen may have meningitis, an infection in the tissues around the brain. And meningitis, by affecting the brain, will cause an ill appearance and sleepiness, even more so when on top of dehydration. In retrospect, meningitis is the most likely diagnosis for what happened to Helen Keller, too. But lucky for our Helen, it's not 1882. Things move quickly. With a nurse's help, an IV is started, and you're dismayed to see that Helen barely flinches. While the needle is in, blood is drawn for testing, and then an intravenous catheter, that is an IV, is left in place to administer fluids and antibiotics. We haven't tested Helen for meningitis yet, but this is a case where therapy cannot wait. We give the antibiotics to treat potential meningitis now, even before performing the spinal tap. That blood that was drawn, the first test done is quick, at the bedside, checking for blood glucose. Hypoglycemia, or low blood sugar, can cause listlessness, though Helen's comes back okay. It's always important to quickly rule out hypoglycemia in children, especially young children, who are listless or lethargic. They have small bodies and have less metabolic reserve than adults, so they're at risk for low blood sugar, especially when they're not eating well or ill or both. Let's let the fluids and antibiotics run in for a few minutes and then see if Helen perks up. We'll repeat a set of vitals too. We had noticed the pulse had been heading up, which is not a good sign. Let's see if that improves and how Helen is doing after what's called a fluid bolus. Meanwhile, we'll think about children and fever. I had said before that fevers cannot harm people, and I meant it. Fever itself is a normal part of the body's reaction to infection, or sometimes other conditions that affect the hypothalamus and its temperature control mechanism. Yet many people are afraid of fevers. They worry that fever will cause brain damage. Why? Well, Helen Keller's story explains why. She had a fever, and when it ended, she was left blind and deaf. For many years, it was thought that fever itself caused the damage. But now we know it's the illness, the meningitis most likely in Helen Keller's case, that caused lasting harm. Still, the fever was there at the same time, so that's what sometimes gets blamed by laymen and doctors alike. There's some evidence, at least in animals, that fever is actually protective, that it helps the body successfully fight off infections. That's less clear in humans, especially humans in the developed world who have access to health care, clean fluids, and antibiotics. Whether or not fever genuinely helps fight infection in a significant way, we know it has some downsides. It can worsen dehydration, and it just makes a child feel bad. So, if it isn't the fever, but the cause of the fever that led to Helen Keller's deafness and blindness, how can we be complacent now? I mean, shouldn't fevers always trigger an emergency department visit and rapid antibiotics? Let me give you a definite answer. No. What's changed since Helen Keller's time is the cause of fevers. Fevers used to be caused by many serious infections that we don't have to worry about now. Polio, hepatitis, measles, and many bacteria that cause blood poisoning are now very rarely seen, thanks to vaccines. In the developed world today, fever in children older than 2 or 3 months is almost always caused by a viral infection that will go away on its own. All you need to provide is comfort care for a few days after a careful assessment confirms there's no likely bacterial or other treatable cause of the fevers. Now, I said we don't have to worry about these infections, but that's not completely true. We do have to worry enough to make sure that kids get vaccinated to prevent these diseases from coming back. With our Helen, even though she's been completely vaccinated, we still need to be careful. Vaccines are never 100% effective. And I also threw in a little twist here, a surprise for our first lecture. Both the Helen Keller and the other Helen cases today are in fact real cases. Modern Helen was my patient in 1995, just a few years before the introduction of a vaccine to prevent infections with the bacteria pneumococcus. That had been the #1 cause of bacterial meningitis in toddlers, and Helen was in fact the last patient I ever saw with pneumococcal meningitis. After the acetaminophen had kicked in and IV fluids were given, Helen did, in fact, perk up. She was willing to sit up in Mom's lap, and I remember her following me with her eyes. Her neck, though, was still stiff. We ended up doing a head and neck CT scan then to make sure that there wasn't an abscess or pressure in the brain. The CT was normal. Then we did the definitive test for meningitis called a lumbar puncture or a spinal tap. Using a small needle, fluid from around the spinal cord was collected. When it dripped out of the needle, instead of being clear like water, it was cloudy like watery milk. Microscopic examination of that fluid showed many white blood cells, and the next day, a culture of the fluid grew the bacteria pneumococcus. But by then, literally the next day, by the time we had confirmation of the expected infection, Helen was already starting to feel better. We had started IV antibiotics in the ED, and by the next day, she was fine. After a few more days in the hospital, Helen was sent home. Many people with meningitis do not do as well. Deafness and seizures are complications, as are later learning problems. Many children with meningitis also have bacteria growing in their blood, causing potentially devastating complications. We don't know for sure if Helen Keller had meningitis. Some people think she may have had scarlet fever or perhaps measles. I think, though, that her presentation with stomach and brain congestion, that is, fever, lethargy, and vomiting, that left her blind and deaf was most likely pneumococcal meningitis. Let me wrap up this first grand rounds with some practical information for parents and caretakers, a suggested fever action plan. This is only for otherwise well children older than 2 or 3 months of age. Babies younger than this need to be evaluated right away for fevers. And children with chronic or serious illnesses or immune problems need to have a more specific plan in place from their own doctors who know them well. This plan is also not appropriate for children who, for whatever reason, aren't fully vaccinated. They're at much higher risk for serious infections and need specific instructions to help decide the best thing to do with a fever. For healthy, immunized children older than 2 or 3 months, the suggested fever action plan I tell patients in my practice goes like this. First, assess just how sick the child seems. If she's really listless and not active at all, or acting really sick, call your child's doctor or head to the closest ED. As long as the child or baby only seems a little sick, you can give a safe medication to reduce fever, typically acetaminophen or ibuprofen. Remember, that's only for comfort. It's not the fever itself that's harmful. We're only treating fever to help children feel better and to help us assess just how sick they act after the fever is reduced. Then reassess the child a half hour later. If the child perks up and feels better, it's unlikely that you're missing anything serious. Call your child's doctor for a routine sick appointment in a day or two for an exam. But if your child really doesn't feel better after the fever is reduced, call your doctor right away and consider heading in for an emergency evaluation. In any case, with a fever, be sure to give extra fluids and jot down when you give fever medicines so you don't get the timing mixed up. You can get the exact dose and timing instructions for your child's size from his or her doctor. By the way, as for what number constitutes a fever, most of us use 100.4 degrees or above, measured with a thermometer. 98.6 degrees Fahrenheit is the average of the normal range of temperatures. That number isn't the normal temperature. Everyone varies higher or lower, so don't worry if your child is a little higher or lower than that. At 100.4 or higher, that's when most physicians would consider a fever to be present. This was a complicated case to start with today, but I wanted to be sure to illustrate some important points. The most important clues about a patient's illness come from the history and physical. What's the story and how did it happen? And what did you find when you examined the patient? The most important part of the pediatric exam is the big picture, the overall impression of how a child is interacting and behaving. We should be very wary of the possibility of serious illness in a child who just isn't acting right. Telling the sick from the well child is a crucial skill not only for pediatricians, but also parents and anyone who takes care of kids. And it's a skill we'll continue to learn about next time. Welcome back to Medical School for Everyone, Pediatrics Grand Rounds. I named several of my lecture series here at the Great Courses Medical School for Everyone because these courses are for everyone. Medical school isn't a mysterious place where the arcane secrets of medical practice are revealed. And I don't think medical education needs to be shared only with people who've got the time and resources to get